Okay, so I'll just kick us off here, and as people are joining us, I just have a couple of housekeeping things. My name is Stephanie Mazzucca. I am on the leadership team of the ISBNPA Early Care and Education Special Interest Group, and I have the pleasure of welcoming you all today. I'd like to thank you for your time and hope that you find these presentations helpful and that we have a great discussion at the end of our time today. I would first like to thank ISBNPA for hosting us, to Antonio and George for their wonderful technical support. There are some other people from our SIG that have done a great job of organizing, so Pouya, Emily, and Anna Christina, so thank you to them. How we'll do things today is we have 2 presentations, and then we have a block of time where you'll all have the chance to ask questions, and we can have a discussion for both panelists at the end, or both presenters at the end. And we would ask you to submit questions through the Q&A box. So there are a series of functions that this Zoom platform offers us, and if you could use the Q&A box, that would be best to compile questions and make sure that they all get answered. And I will turn this over to Emily to get us started.
Thank you. I'm very pleased to be able to introduce our expert panel for today's webinar. We have 2 wonderful speakers. We're very grateful for their time and their expertise. I know this topic is of great interest to me, and from being at the annual meeting this year, the issue of sleep, particularly as it relates to obesity, I know is a very hot topic that seemed to come up again and again. So we're very excited about today's presenters. So I'll go ahead and introduce both of them now to allow for them to have more time and to transition between their talks. Our first presenter will be Dr. Rachael Taylor, who's joining us from the University of Otago in New Zealand, where she is professor and deputy head of the Department of Medicine, among other hats that she wears. And what I really love about the society and the international aspect is that she's joining us from Friday, while I'm stuck here on Thursday, probably with many of you. So her work addresses multiple lifestyle behaviors related to weight health across the lifespan, but with a particular focus on childhood. So she will be talking to us today, giving us a little bit of background on sleep and the importance of sleep in childhood, and then some really useful information on sleep assessment. And then following Dr. Taylor, our second presenter will be Dr. Jess Haines, who is Associate Professor at the University of Guelph in Canada in the Department of Family Relations and Applied Nutrition, which I think sounds like a lovely combination of disciplines to address some of these issues. Her work also considers broad behavior determinants related to obesity in childhood, with a focus on interventions both at the family level and the community level. And she will be sharing her work as it relates to that at the sleep as a component of some different interventions. So again, we're very grateful to both of them for joining us today. I think they have very exciting and complementary expertise. So at this time, I'd like to invite Dr. Taylor to begin her presentation.
Great, well thanks very much to ISBNPA and to Emily and Pouya in particular for the introductions, and to Pouya for the organisation. So really Pouya asked me to talk about 3 things. How do we measure sleep? Why is it important for children? And then in particular the relationships between nutrition and sleep per se. So I'm just going to start with the measurement. Really, there are 5 different ways of measuring sleep behaviour in children, and this ranges from the vastly most common method of using relatively crude questionnaires right round to the gold standard method of polysomnography. And we'll just talk about each of those briefly. Now, it depends really what method you choose. Like anything, depends in part on what you actually want to measure. And my work really covers the obesity space, and the vast majority of literature in the obesity space has really looked at sleep duration itself. And so in the main, that's of course the amount of sleep that occurs over the night period. But of course for this particular age group, there's also some consideration of naps and sleep that occurs during the day. Sleep duration is relatively straightforward. Sleep quality is a much more complex field. And I've just put there for you a range of the different factors that are considered to sort of come under the sleep quality umbrella. So you might be interested in what time a child goes to sleep at night, for instance, their sleep onset. You might be interested in their sleep efficiency. So that's the sort of, once you go to sleep at night and wake up in the morning, what percentage of that time has the child actually spent asleep? You might be interested in their latency. So when they first start trying to go to sleep, how long does it actually take them to get to sleep? And there are all sorts of scales for looking at sleep disturbances and so on. So if we just start with questionnaires, one of the main things to remember is that they're predominantly measuring time in bed. And this is particularly the case when you're asking parents of young children. Unless they're physically sitting beside the child, waiting for them to go to sleep, which does happen, what you're tending to get a measure of is time in bed, not time they went to sleep. Now that's also the case for perhaps awakenings in the night or how the child is learning to self-settle. Now a child learning to self-settle is actually a really important component of developing good sleep habits long term. So unless the child has called out to you, the parent doesn't often know of the awakenings or exactly how that works. Now if you're writing a paper on apologies, that's the rescue helicopter coming in. It might be noisy for a little bit. But sleep duration measures by questionnaire do correlate with actigraphy measures of sleep, for instance, but they're only sort of low to moderate. So it's our most widely used measure, but there are some problems, of course, as there is with all questionnaires. What you don't tend to find in the obesity literature nearly so much, but certainly in the sleep literature itself, is people using sleep diaries. And this has some advantages over questionnaires because most questionnaires ask about usual sleep or typical sleep. And we know that sleep is actually a very variable behaviour in children. So at least diaries hopefully give you actual sleep over a certain defined time period. And they're often pretty simple for parents. You ask them to fill in something like on the bottom of your screen there. So they just draw a line in 5-minute blocks when the child is asleep and when they're awake. What we find in reality, though, of course, is that a lot of parents fill these out the next day or at the end of the week or whatever, so they're not often completed in real time. Actigraphy, use of accelerometry or actigraphy is certainly growing. It's lovely and easy for participants, particularly with the wrist or ankle worn as they're typically used in sleep models. Some are bulkier than others. And there's certainly increasing use in the collection of 24-hour data. So we've been collecting 24-hour data sort of since the early 2000s. And one of the big things to remember is it's actually quite difficult to analyse in lots of ways. But the most important thing to remember really with actigraphy is that remember accelerometers are measuring motion or acceleration. So all you are doing is inferring sleep as the absence of activity rather than measuring it directly. Now, when you have the night period, that's generally reasonably easy to do. But for this interest group, measuring daytime sleep in young infants and toddlers or in night shift workers, for instance, and older adults is actually quite complicated with actigraphy. And the analysis time, of course, can be quite extensive. Just one thing to note, as there is increasing awareness of the use of 24-hour measurement and accelerometry, you actually have to account for your sleep period really accurately, particularly if you're interested in measures of sedentary behaviour in particular, but also activity at the light or overall level. So this is from a colleague of mine who took children and they had a week of accelerometry data, and these were 6 different ways essentially of removing effectively the sleep period from the 24-hour data. So in the first one, 24 hours, she didn't remove any sleep at all. This has been used in the literature. The next 2, she just removed a blanket amount from every kid, so either midnight till 6 a.m. or 9 p.m. to 6 a.m. Diary means that for every single day, for every single child, she used the parental reported bedtime and wake time. And then you have 2 algorithms. Saeedi is the one that's built into your ActiLife program, and so that's what most people use, but not all. And then the last one is the count-scaled algorithm, which is work from our group that uses a bit more sort of fancy work to try and smooth out some of those epochs. I really just want you to look at the sedentary time in particular. So that's the minutes over that full 24-hour period that was then classified as sedentary time during each of those methods. And you can see the huge variation that exists across there. You also see significant variation across counts per minute. So if you're using that as an index of overall activity and have not accounted for sleep properly, then you're going to, run into problems. And even light activity was showing some differences there, but it doesn't affect moderate to vigorous, as you can see, and that's perhaps not surprising. We do see, definitely not in the obesity space, but in the sleep literature, the use of videos. So you have to go into the bedroom and set up a fixed video camera and you leave it going all night. So it's fantastic for looking at particularly parental interactions with infants, or the use of self-settling techniques and how infants and toddlers are getting themselves back to sleep. But there are 2 main things, of course. Pretty invasive, as you might imagine, getting yourself videotaped while you're asleep. It's very time-consuming to analyse. And we're, of course, interested, babies don't always sleep in their cot or bed. They often sleep in their pram or stroller or out in car seats, so you're missing a lot of their napping as well, potentially. And lastly, of course, our gold standard method. Now, both of these wee fellas are hooked up to polysomnography. One on your left is in a sleep laboratory. The one on the right happens to be a little one I know, and he's ready for home PSG. You can see it's a fairly complicated procedure. There's lots of electrodes and all sorts of bits, and they're hooked up to machinery. So if you're trying to measure usual sleep, that's unlikely to happen in the laboratory environment. However, there are portable models that allow you at least to measure sleep in the home environment, but as you can see from the photo on the right, it's still fairly involved and not really a very natural environment for children, if you like. So there's lots of interest in whether children are actually sleeping less than they used to. And certainly that's something that you will see mentioned often in the literature. And Tim Old's group, Sarah Blunden and so on from Australia have actually done some quite interesting analyses related to this. And this is from a paper of theirs a few years ago where the open circles and the solid line refer to the change in sleep recommendations that's occurred really since the start of last century. And then the filled in circles and the dotted line refer to measurements of actual sleep duration, the vast majority, as you might imagine, by questionnaire. There are 2 things really to note. One, the variability in recommendations at any of those particular time points, and B, perhaps that they've decreased over time, but certainly that actual sleep duration generally is less than recommended sleep duration. So sleep's only really hit the obesity literature. 1992 was actually the first paper, and there have been a lot of papers since then. But concern about sleep has actually been around for some considerable time. So this is a quote from an editorial in the BMJ about how the hurry and excitement of modern life is really responsible for much of the poor sleep that actually occurs. What's interesting about this editorial is that it's actually from 1894. So concern about sleep has actually existed for some time. So why is sleep important for us in this particular group? These 3 are really the ones perhaps of predominant interest to this group. And the sleep obesity literature has really grown exponentially in the last few years. And so this is Fatima's review from a couple of years ago now that only looked at those prospective studies which had investigated the link between sleep duration and obesity in children. And one thing to note really about this literature is it's actually incredibly consistent. The vast majority of studies do show a relationship, and in particular these prospective ones. So a child who's a short sleeper has about double the risk of a child who's classified as a long sleeper. Does being active make a child sleep more? Intuitively, we believe that's the case. And for those of you that are parents, you know, it's something that's a commonly believed thought. And certainly in the adult literature, there's quite reasonable evidence that exercise is good for sleep. In children, though, it's been a lot more conflicting, if you like. For a start, there actually isn't much literature that has directly examined this question. And B, the actual evidence is not very strong. It's mostly observational. There have been very few interventions that have actually tried to show that this is the case. If anything, sleep seems to be more related to sedentary time than physical activity time. And so the table was giving you an example of that. So that's showing that if you have a later bedtime, you will have less sleep, more sedentary time and more light time, but nothing to do with moderate to vigorous physical activity. And that's been quite hard to explain in the literature. If anything, if there's a relationship between sleep and moderate to vigorous physical activity, it seems to be more in the negative direction. So kids who sleep more will be less physically active. But a big part of this is the fact that 24-hour data must be analysed appropriately. So particularly if you've used accelerometers to collect all of that information, you have 4 main behaviours of interest, if you like. You have sleep time, sedentary time, light activity, and then moderate or vigorous activity, perhaps combined. If one of those variables increases, one of the other variables has to decrease, because you've got that fixed 24-hour time period. Now, you don't know if that decrease is a genuine decrease or the result of being within that fixed period. So there are ways of analysing 24-hour data, but that must be done appropriately from a statistical point of view. So what about eat healthily? We're going to cover that at the end. So just going to mention very briefly the other sort of 2 main areas in the sleep space. And one is really tied up with academic performance. So there's a lot of interest in how sleep may be impacting academic performance. And so this is a meta-analysis from a colleague of mine, really looking at sleep-disordered breathing, which is sort of covers a spectrum of sleep issues. It might be from habitual snoring, which is actually in around 10% of children, to those who actually have established sleep apnea, which is anywhere from 1 to 4%. And you can see there that there is a significant effect. So those kids who have sleep-disordered breathing don't perform as well at school. There are quite a few problems with the literature. Academic performance has been evaluated a lot of different ways. The effect sizes are only small to medium, but there's certainly interest there that it is an issue. And then the last one there is about mental health. Now again, anyone who's a parent will know, or you'll know yourself, if you've got a tired child, you've generally got a pretty crabby child. And so this is a summary of the literature that's looking at the relationships between sleep duration and basically a child's ability to handle their emotions, to handle themselves in times of stress. You can see there, like most of the sleep literature, it's vastly cross-sectional, with a few longitudinal studies and just a handful of RCTs. So this is quite a consistent finding. But you can see that mostly, and I guess it won't be any surprise to anyone there, that sleep duration does seem to be related to that emotional regulation. Just to note, though, that very little of that literature has used objective measures of sleep. So that's a big area of gaps. We're not going to talk about risky behaviour because of this particular age group of interest, but there's also quite a lot of literature in adolescents looking at sleep in relation to driving, drug use, alcohol, smoking, and so on. So just lastly, I'm going to finish with diet before I hand over to Jess. And unfortunately, there's not a huge amount of literature that has examined the relationships between sleep and diet for your particular age group of interest. So there's a few studies, but I've really had to supplement those to give a bit of a picture of a wider thing with slightly older children. So this is an example, for instance, of one of the cross-sectional studies that exist. It's in a pretty large sample of 7,000 Spanish children, but all they had was a pretty crude FFQ, 21 items. They asked about frequency only, so no information on serving size, and they really just compared the difference in frequency of intake for those who slept more or less than 9.9 hours per day. So generally speaking, the longer sleepers had a more healthy diet, as indicated sort of by greater frequency of milk, yogurt, fruit and vegetables, and lower frequencies of things like sugary drinks and chips. But the differences are pretty small. It's cross-sectional. We don't actually know if eating badly makes you sleep poorly that night, or perhaps if sleeping poorly in turn makes you want different foods the next day. So cross-sectional data is pretty limited, as we know, in that context. This one's a little more involved, one of the very few longitudinal studies in your age group of interest. So it's from Project Viva. And so they had about 1,000 children in the sample, and every 6 months from birth to 7 years of age, they got an estimate of sleep duration in the children. At each of those time points, and it's up to 13 time points, children were then given a score of 1 if their sleep duration met recommended levels. So a good sleeper would be a child, for instance, who had 12 or 13. A poor sleeper would be a child who never met any of the recommendations. As you might expect, most of the kids were really in those 3 middle categories. They assessed their diet with FFQs, and they found that you did see a lower dietary quality as measured by this Youth Healthy Eating Index in children who were poorer sleepers. So the diet was measured at 7. So sleep was measured from 0 to 7 years, diet was measured at 7. So it did seem to suggest that poor sleep led to poor diet later on. But the relationship may also exist in the other direction. So this is also from a large study, the Generation R study, that involves more than 3,000 children, and also in your age group of interest. And so what they did this time was assess the diet at 1 year of age and then sleep at 2 to 3 years of age. So they were wanting to know if poor diet predicted later poor sleep. They did a fairly complicated nutrient substitution model, and so the bottom line here was that children who had protein or carbohydrate at the expense of fat slept more at the age of 2 than children who had higher fat diets. But the differences in sleep there were only about 4 to 6 minutes per 5% change in the macronutrient content. So basically protein or carbohydrate seemed to promote sleep a bit more. This is in older children, so not as relevant to you guys, but there's a lot of interest, of course, in other aspects of eating behaviour. So this was, again, from a large study that assessed a whole variety of things, and only 3 of them were significant at the multivariate analysis. And so it's essentially showing cross-sectionally that poor diet might also, that sleep was also associated with some other aspects of eating behaviour, but the data were fairly crude. So really our best level of evidence to finish with are our 2 experimental studies, only one of which is in your age group of interest. So a very small study of 10 children, but very well-run study. They essentially sorted out their sleep for about 5 days, and then on a single night they sent the kids to bed 2 hours later than they were used to, but made them get up at the same time. So they had a single night of sleep restriction and then a single night of sleep recovery, all measured by actigraphy. They did dietary recalls on both restriction and recovery days, and the important difference to note there is the difference in sleep that you can see down the bottom. So a big difference of 3 hours of sleep, but it's really the energy intake. So once they'd had that sleep restricted night, they ate 21% more energy on their restriction day than they had on the previous day. But even after a recovery night of sleep, they were also eating significant more energy at about 14%. The only corresponding study in slightly older children from Hart et al. Actually did 5 nights of sleep, and they also made a difference between the sleep here of a couple of hours a night, and the energy difference was quite a lot smaller. It was about 7%. So, you know, that 21% estimate from Mullins may be an overestimate from a single night, but there's no doubt that experimental sleep restriction studies do show that it affects dietary intake in children on the basis of the 2 existing studies in the sort of under 10 age group. So really, in conclusion, we know sleep's important for a whole range of health and well-being. But the literature really has been limited to questionnaires, predominantly cross-sectional, and relatively few tools. We really need some longitudinal studies, some experimental studies, some 24-hour data, some objective measures, and so on. But certainly there's no doubt that sleep's good for us, as we all know anyway. Thanks very much.
All right, and I'm going to continue. Thank you so much, Rachael, for clearly outlining the importance of sleep in children's health and in obesity risk for sure. So I'm going to continue the conversation by talking about obesity prevention interventions that have specifically addressed sleep in young children. Because this area, as Rachael identified, this area of research is relatively new, I'm first going to briefly describe some of the lessons that we've learned from interventions designed to treat sleep problems in children. And then I'm going to specifically talk about some obesity prevention interventions that have addressed sleep early in life. The first two I will talk about, the prevention of overweight in infants and Insight, both delivered the intervention during infancy, and Healthy Habits, Happy Homes delivered the intervention in preschool age kids. And then we'll briefly sort of have a summary and hopefully jump into next steps and some questions from the participants. So evidence from treatment interventions suggests that parent education along with behavior modification is effective in reducing sleep problems in children. The focus of this behavior modification has been to improve sleep hygiene, which Jody Mindell has defined as modifiable parent and child practices that promote good sleep quality and allow for sufficient sleep duration. So when we're thinking about these practices that help improve sleep, what is it, for sleep hygiene practices that we can do to improve our children's sleep? Well, one is the environment with which we create for the children to sleep. One is to create a comfortable space, so it's dark, quiet, cool, with good airflow, allowing them to sleep comfortably. There should be no TV or media in that sleep space. Also creating a consistent routine for children. So one is that there's a consistent time that they go to bed and wake up each day. As Rachel's data suggest, even a small change seems to have a big impact. So trying to have fairly consistent sleep to wake. That there's a consistent bedtime routine, that kids are familiar with what's going to happen to help get them to sleep. Also, when we have our sleep routine, it should be promoting independence in sleep, so avoiding rocking children to sleep or falling asleep with the child, and that there should be no screen time before they go to bed. And when looking at daytime activities, physical activity remains up for debate, but there's certainly some good evidence that avoiding caffeine use, which of course isn't relevant for infants, but there is some evidence that even preschoolers who have caffeine, it can affect their sleep. And when we look at the research that the studies that have looked at sleep hygiene practices among the general population, so not families who are getting treated for sleep problems, it really seems that we have substantial room for improvement with regards to our sleep hygiene practices. Up to 75% of parents incorrectly estimate how much sleep their child needs. We found that over 60% of preschoolers have screens in the room where they sleep. Using a television or a screen as part of the sleep routine and having to help children fall asleep is also common. We've also found a lack of bedtime routine in some families. Some research has suggested up to 40% of families don't have a sleep routine, and we certainly found that working with families when we talked about routines and asked them, many of them would tell us, well, my child goes to bed when I go to bed. So there was no little effort to sort of create a child-specific routine or no thought about sort of how to do that. So certainly when we're thinking about improving child sleep as a way to reduce obesity, it appears that our interventions should give some thought to how to support families in creating healthy sleep hygiene practices. And the first intervention that I'm going to describe that tried to do that is the prevention of overweight and prevention of overweight in infancy. This is an RCT in New Zealand that Rachael led that aimed to determine whether a conventional approach or an intervention focused on healthy eating, activity, and breastfeeding, or an indirect approach, which is one to promote healthy sleep habits, or a combination of the two, would reduce body mass index at 2 years of age compared with standard of care. And I'll talk a bit in 2 slides about what standard of care looks like in New Zealand. Rachael and her team recruited 802 women who were pregnant, and they could be pregnant with either their first child or a subsequent child. The demographics of the women that they recruited, the vast majority were New Zealand European, but there was also about 6% Maori, 1.6% Pacific, and about 5% Asian. 60% had a university degree or higher. But with regards to socioeconomic status, there was quite a spread with sort of similar numbers of families, or similar percentage of families with low, medium, and high socioeconomic status. So standard of care in New Zealand consists of a series of free and clinic visits with a midwife and then a nurse. The visits focus on growth and development, guidance about breastfeeding, nutrition, parenting, safe sleep, as well as smoking cessation, safety, and family health. And so all the women would have received the standard of care, but then those randomized to interventions in the food, activity, and breastfeeding. There was a session before birth, and then some visits with lactation consultants, as well as with the nurse on diet and activity focus. The sleep intervention involved 2 contacts, one before birth and one as a home visit at 3 weeks, and I'll talk a bit about what happened at those in just a minute. And then the combo had both. There was also availability, so if the nurses identified that there was, if parents identified that they felt their child had a sleep problem, they were referred to treatment, and about 26% of participants in the sleep and combo got that extra treatment. So in the prenatal session, or sorry, the pre-birth session, they provided some support, mainly trying to get parents, the women, ready for sort of setting realistic expectation about what sleep would look like in those first few months of life. And then at the 3-week session, they had a home visit from a nurse, which provided resources and discussion around how to develop good and safe sleep hygiene with their infant. The intervention was with regards to looking at the effect of BMI and weight status. There was no significant difference between the groups with BMI and BMI Z-score, but there was a significant difference with regards to level of obesity, with lower levels in sleep in the combo group compared to the other. The team also did an unplanned post-hoc analysis, trying to get a sense of if they sort of combined groups, so looking at those that received the food, activity, and breastfeeding versus those that did not. Was there a difference in obesity risk versus sleep versus no sleep? And there was a decreased risk of obesity among those who had sleep versus no sleep. So some suggestion that something's going on when we provide supports around sleep. But interestingly, the team did not find any difference looking at sleep duration, and they measured sleep duration both from parent report, but also with accelerometers worn on the hip for 5 to 7 days. There was also no difference with regards to parent-reported frequency of waking, sleep problems in the child, or their sleep practices. And so this is a bit curious because it certainly suggests that something's going on with the sleep intervention. And one thought that the researchers discussed in their paper is that it may be that promoting effective sleep practices may actually have an impact on children's sort of general self-regulation. So it may not be specific to sleep, but is there sort of some sense that if you provide more independence around sleep, children have developed sort of general self-regulation skills? And the intervention did do follow-up. The data is just available now, and they did look at self-regulation. And I don't know, Rachael, if you have a comment or two that you'd like to make?
I can give you the thing in a nutshell. We've just literally got our 5-year results off the press, so we've done a follow-up at 5 years of age, and the results are sort of almost more impressive at 5 years than they were at 2 years. So what we've actually found is that the sleep group still have a halving in their risk of obesity at 5 years of age compared to the kids who didn't get sleep. So even that very, very light intervention from almost 5 years ago has still made an impact long term. But what was also intriguing is that the FAB group are actually worse at the age of 5. So they had a significantly higher level of obesity. And I think that gives some really interesting ideas about, I'm a nutritionist by training, but is nutrition and activity the right way to go at this age group?
Great.
Thanks, Jess.
Excellent. Thank you. That's really helpful in cutting edge data. Great. So the second intervention I'm going to talk about is the Insight intervention. And this is an RCT done in the US that aimed to determine whether a parenting intervention that used a responsive parenting framework that addressed sleep, but also infant feeding, emotion regulation, active play, as well as learning about sort of appropriate growth for children, would produce both rapid infant weight gain as well as overweight at age 1. And this is based out of Penn State with Ian Paul and Leanne Birch, as well as Jen Savage leading the work. In their intervention, they recruited women who just early postpartum, so had just had a baby in a maternity ward, and they had to be have had their first baby. And they recruited 279 women. Approximately 90% of them were white, a relatively high level of education with about 55% who were college graduates, and also overall a fairly high socioeconomic status group. The intervention was delivered by nurses who delivered the intervention through home visits. There were 4 home visits throughout the first 40 weeks of life. The sleep intervention focused on helping create a bedtime routine, thinking about sleep location and behaviors around that support adequate sleep, and also how to respond to night waking, and with a big focus on alternative approaches versus feeding in the middle of the night. The intervention included, they mailed a video on alternative soothing strategies to use at night, using the Happiest Baby on the Block video. The nurses also used the infant sleep questionnaire and gave feedback to the families at both 16 weeks and 40 weeks to tell them a bit about how they're doing with regards to sort of recommended sleep hygiene practices. This group did find that the responsive parenting group did have a lower prevalence of overweight at 1 year compared to those in the control. And they also found some differences with regards to sleep outcomes. They only had parent-reported sleep, no objective measures, but they did find that parent-reported nighttime sleep was higher at a number of the, at 8 weeks, 16 weeks, as well as 40 weeks, but with no difference at 48 weeks. They also found that they were, parents also improved some of their parenting practices with regards to sort of soothing, using other things other than food or attention throughout the intervention. So some suggestions certainly that improving some of these sleep outcomes may lead to improved weight outcomes in infancy. And lastly, looking at healthy habits, happy homes. This was an RCT done in the US. I did this work along with Elsie Taveras, and we looked at whether a home-based intervention that aimed to increase sleep duration, family meals, as well as lowering screen time and screens in bedrooms could result in a smaller change in BMI as compared to a minimal attention control. In our case, our control got emails about sort of general growth and development of children throughout the intervention. So our characteristics, we did this work outside of Boston. The vast majority were Hispanic or Black, and a high number were low income in both the intervention and control. We also had child characteristics, looking at the mean age of the kids was about 4 years, and despite it being a primary prevention intervention, we didn't recruit specifically for overweight or obese, but about half of the children were overweight or obese at baseline. Our intervention involved home visits by health educators who were trained in motivational interviewing. These folks also provided telephone calls throughout the 6-month intervention. The home visit focused on helping with regards to sleep, focused on creating sleep routines for their child and supports around how to do that. We also sent text messages with guidance on sort of how to create healthy sleep hygiene, so not having TV, for example. And then we also mailed education materials to support the health behavior. So for bedtime, for example, we sent a book that could be part of their bedtime routine. So here's an example. We gave sort of tips about how to create a bedtime routine and what's a healthy bedtime routine. And then we had families create, one of the strategies was sort of have them think back. If they wanted their child to sleep, 11 hours, what time would the bedtime routine have to start in order for that to happen so they could go to bed and sleep that adequate amount of time? So we helped them think through that and then record whether or not they followed their routine each day. We did see a change in parent report of sleep duration. We did not have an objective measure of sleep, but parents, compared to those in the control, parents in the intervention did report that their child slept about 40 minutes or so more each night compared to those in the control. And we did see some change in objectively measured BMI. So compared to those in the control, our intervention kids had a lower BMI adjusted for both age and sex. So again, some suggestion that maybe if we can help improve sleep, we can improve child weight outcomes in the toddler age. One of the interesting things we learned from Healthy Habits, Happy Homes is that certainly parents were responsive to this idea of changing their child's sleep. One of the things that made it more attractive than some of the other things we were asking them to do, like as opposed to having them reduce screen time, which meant sort of more work for parents, we would tell parents, if we can create a sleep routine and your kids go to bed earlier, that could be more time that you have for yourself. So it made it sort of an attractive, they were interested in sort of, can I improve my child's sleep? And again, as Rachael mentioned, sleep, of course, impacts children's behavior. So that was attractive to parents too. Also, intervening in the home setting was instructive. Being right where people actually have to implement their routine was helpful and certainly allowed health educators to adapt their advice directly to the environment where they were. Some limitations, certainly we don't have an objective measure of sleep. It had a short follow-up time, and we didn't assess cost effectiveness. So thinking about overall what we learned, so home-based interventions focused on sleep seem to be effective at increasing sleep duration and potentially improving some sleep hygiene practices, which may lead to improved weight outcomes in kids. We definitely need more research that's using objective measures of sleep. I think we also need to need more research to identify which sleep hygiene practices are most relevant in the prevention context. When we don't have a sleep problem, what are the ones that are critical that actually improve kids' sleep duration and quality? What are the most effective strategies for changing those sleep hygiene practices? I don't think we know that yet. What's the required dose to make it effective? What timing? Is infancy the right time? Do we need them throughout these early years? Or maybe, as Rachael's long-term data suggests, if we intervene really early, we may have impacts, 5 years out. So that might be a critical time. Also looking at sort of key mediators of behavior change. What are those key factors we should know about? And what are the mechanisms for how these lead to lower obesity risk? And again, I think Rachael's data is really interesting. What's going on when we talk about sleep? How is it that, that changes obesity risk? I think that's really important to look at. And I also thinking knowing more about cost effectiveness just allows us to advocate for some of this work with our policy folks as well. And so thank you so much. And I think we are now able to take your questions.
Wonderful. Thank you so much, Jess and Rachael, for the great talk and sharing this information with us. We received a number of questions and we will try our best to cover them all. But for now, the first question is from Dianne, and she wants to know if there are more sleep difficulties in children with attention deficit disorder or maybe other behavioral issues. And either of you maybe can cover this question.
Yeah, well, certainly there is quite a body of literature looking at ADHD and some of those other things in relation to sleep and the prevalence of sleep problems and difficulties of sleep. Not surprisingly, perhaps, is pretty high in those population groups. So yeah, definitely an issue for them. Whether it's higher or not, there haven't been that many direct comparisons, but certainly it is an issue.
Thank you. This is Anna Lindsay, one of the other moderators. We also have the next question to Dr. Taylor, and thank you to both Dr. Taylor and Dr. Haines for an excellent presentation with lots of great information on this great topic. So for Dr. Taylor, from Nicholas Kuzik, with the gold standard measure of sleep, the polysomnography, having a potential for sleep disruption, what is the best approach for validating tools for field use?
Yeah, I mean, it does cause issues. I mean, the PSG is not terribly natural for children when they're doing those measurements, but it gives you an incredible wealth of data that really do allow you to measure sleep in all aspects. So it's the only tool that measures sleep quality, in particular waking. So actigraphy is quite limited in its ability to detect when a child wakes. It's quite good to detect when it goes to sleep, but waking is where the real issue lies. So portable PSG is still our best, laboratory PSG is still our best measure. Portable is a bit of an in-between, if you like. So if you're going to validate these tools, in the ideal world, you would still be validating them against PSG. Now, even if your sleep variables from your PSG aren't particularly normal, remember, in your validation, you're still just trying to sort of validate each epoch, if you like, from actigraphy against each PSG epoch. So the fact that it's not quite their normal sleep doesn't actually matter too much from a validation point of view. If you were trying to use PSG to measure natural, normal sleep, then obviously that's not the case. But as whether your tool can pick up sleep versus wake, you really do need to go against PSG in the ideal world. Most people, of course, are just validating other tools against actigraphy and various things with all of the limitations.
Thank you. And the next question is from Margaret for Jess, and she wants to know if the association between sleep duration and growth has been assessed in this INSIGHT cohort.
Whether or not the question, sorry, can you read it again?
Yeah, if the association between sleep duration and growth has been assessed in the INSIGHT cohort.
I don't think so. I don't think they have looked at different, there's a new paper out with Ian Paul as the lead looking at sleep hygiene practices associated with sleep duration, but I do not think they have yet looked at sort of the mediation influence. So as the intervention changes the sleep, do we see a difference in the weight outcomes? That hasn't been done that I know of, but I think is a really interesting question that helps us get at some of those mechanisms of these interventions. What is it? Maybe that's critical, and maybe that's where we should be spending our time, as opposed to, these since we're, as opposed to focusing on a bunch of behaviors for folks, maybe it is exactly that sleep may be the one that's critical for the change. So I don't know of a paper that's done that yet in INSIGHT, but I think it's a good question.
Yeah, thank you.
This is Anna again. We have another question from Dianne. Do you think, and she didn't identify a particular speaker to answer the question, so it's for both of you. Do you think that the relationship between less sleep and more obesity in toddlers and preschoolers could be similar to parental feeding of a crying baby, especially at night? Maybe children exhibit crankiness and are offered food as a way to soothing these kids.
Yeah, well, certainly. I mean, that was really the whole premise behind the INSIGHT study, as Jess outlined. Certainly not the only reason, but it's something we addressed in Pouya as well, to really not use feeding as your first way of soothing an upset child, that you do try a whole variety of other things, because it is tempting as an exhausted parent to offer a child either the breast or a bottle in that infancy age group, because a lot of the time it works quite well.
And I think in preschoolers, it would be really interesting to look more at the mechanism between sleep and obesity that may go through parental feeding, meaning you've got a child who's not able to manage their emotions well, and one of the ways you're soothing them as a parent is providing them food that they enjoy to sort of help that. Would be I don't know of any studies, but that's a really interesting question that I think understanding more the mechanism would be really, because Rachel's work suggesting that they're not eating as well, it'd be interesting how parental feeding interacts with that.
So, I mean, we looked at parental feeding. We didn't find any differences in terms of parental feeding practices across our intervention groups, nor any differences in diet. And I think that's why the experimental studies that I mentioned at the end that try and measure those things more carefully, if you like, are actually really important, because you know, in the under 2-year age group, it's incredibly difficult to change diet, to change nutrient intake. What we do see are differences in parenting practices. And so a lot of those infancy studies have made an impact on parenting practices, but not necessarily sort of across well, ours is the only one that looked at sleep per se.
Great. And our next question is from Anna, and she wants to know, given the limitation in the current literature, what are the main suggestions for advancing the science related to sleep as an obesity prevention behavior? And I think either of you again can cover this question.
I think Rachael hit a number of them really clearly. I think both in intervention work and in our observational work, having better measures of sleep is going to improve our understanding of the impact of sleep. I think, as we've talked about just in the question period, understanding more the mechanisms by which changing that sleep, and with strong experimental studies, better, more frequent measures in some of our more observational work, I think is going to help us understand better what is it about sleep that's leading to this obesity risk, and then that should inform clearly the types of things we should be addressing in our interventions.
Yeah, I would agree. I mean, we need to measure it better, excuse me, and we need to analyse it better, because a lot of the analysis has been fairly crude in lots of ways, particularly if we're going to be using the 24-hour data. We really have to address that properly. It's critical.
Great, thanks.
Great. We have a question from Pooja. Could you comment on any research related to daytime sleep, nap time, and relationship with obesity? Many of us focus research interventions in early childhood education settings where nap time is often required in the US.
Yeah, there's certainly a lot of interest in that, but very, very little data. The data that do exist don't tend to show any relationship. The relationship does seem to exist with the night's sleep, but it really is based on pretty limited work. And I know there is interest, particularly in that US situation. In New Zealand, it's a wee bit more lenient of whether naps are compulsory or not, but they're generally in the ECE environment as well. And that it may actually have some disadvantages to give children a required nap. So yeah, unfortunately, just probably not enough literature yet to give you much of an answer, except that what is there doesn't tend to suggest much of a relationship. But our measurement of nap has been, as I've mentioned, actually quite poor.
There is another question from Bridget, and she wants to Rachael to talk about proper analysis of the 24-hour data.
Okay, so I'm not a statistician, so I can't actually give you the nitty-gritty, but you will need a statistician to do it for you, basically. So they use, I mean, the term that's often was coined by a different group is compositional data analyses, but basically you have to use statistical techniques that can that properly account for the effect that if one behaviour goes up, another behaviour has to come down within a fixed window. And so they are actually different. There's no single best method, you know, like statisticians like the rest of us, nutritionists, whatever, we always argue about what's the best method, so they're the same. So there are different ways of doing it, but compositional data analysis is perhaps one of the ones that you would have seen most, but it's just statistically handling the data properly.
Perfect. I have another question, and it's just my own question. And I just wanted to know how we can correctly estimate the amount of sleep each person needs. I mean, how we can understand that?
We don't know. Sleep need is actually a very, very difficult thing to assess. And some studies have tried to do it, but not a great deal. So most of the recommendations that exist around the world tend to actually be based on usual sleep rather than recommended sleep. And so really you need those experimental studies that would actually, put person in a varying degrees of sleep restriction and extension and measure their behaviour and weight and emotion and all those sorts of things. But sleep need is actually difficult or if not impossible to determine at this time.
Great, thanks. And just one more question. What is your recommendation? I don't know how scientific is that, but recommendation listening to music before sleep for children. Do you recommend this, or is it, interfering with independent sleep? Is it a good way for children or no?
I don't know, I'm not sure what Jess did in healthy habits, but certainly reading or quiet music would be one of the recommended activities. So I think the answer will really depend on what you're listening to. We've got some work in adolescence showing that music can actually be detrimental to a child's sleep, and I think that really will come down to what they're listening to and so on. It'll be like anything. If you watch exciting TV, it's going to probably disturb you a lot more than if you're watching something very quiet and peaceful.
Absolutely, and in fact, if it's calming and it's a part of the ritual, often kids will respond well to it.
Not something we saw much at all in reality. There was telly or reading, and unfortunately not a huge amount of the latter.
Thank you.
We have one more question from Adam. He first wants to thank both presenters for their great presentation, and he's curious to know whether there is any research that measures maternal tiredness as a proxy for coping perhaps in the first year of life, and whether paternal involvement during that first year results in better sleep weight outcomes after the first year of life or beyond.
Yeah, well, certainly maternal tiredness undoubtedly plays a factor. And so that was one of the things that we measured in Pouya, for instance, and maternal tiredness, not surprisingly, in the first year of life was incredibly common because it's almost, but it's also something that, part of our antenatal session, as Jess was outlining, was setting realistic expectations and the fact that you will be tired, and you might actually be tired for a whole year or longer or whatever, that you're having a massive change in your life. And so part of our study was actually trying to get them into the headspace to expect the tiredness so that it didn't come across as a shock, and that if your Auntie Beryl told you that all her children slept through the night at 2 weeks, Auntie Beryl's actual abnormal, not normal. So that, it's about setting realistic expectations is important. Again, anecdotally, of course, we know that paternal involvement is important, but I'm not actually sure. My research tends to focus more on the obesity side of things. I'm not aware of any research, that doesn't mean it doesn't exist, really showing the paternal involvement and how much that affects, but I am sure it will have some involvement. Jess may know more.
I don't know more, but I think it's a great thing to measure. Especially as we're doing more family-based work, to understand how both parents participate early in life, and how that improves outcomes both for the parents and for the child.
One thing I can tell you is that you can get, we ask both mums and dads most of the questions all throughout Pouya, and mum and dad can give you quite different answers about whether their child has a sleep problem and so on. So it probably is a very understudied area.
Great. Well, thank you to both of you so much for sharing your expertise related to sleep. I think I even picked up a couple tips as someone who doesn't have kids on things to think about for my own sleep routine. So if you have any other questions, please feel free to contact us by email and we can put you in touch with our presenters today. And we look forward to seeing you all at the annual meeting in June. So thank you very much.